Right, let's go. Assuming I can think of anything to say, of course. Right, we're doing head injuries today, aren't we? Well, Jean is doing head injuries this afternoon. So let's start off with a couple of pictures. Start off with a boxing glove. Did we do this before? I can't remember. Did we do boxing gloves? Yeah.
Big boxing glove?
Yeah, you always do biggish diagrams. So the boxing glove is the top part of the brain, isn't it? The larger part of the brain. And on this model, it's that bit on top. And we call that the cerebrum. So the cerebrum is the top of the brain. And then as we see on this model, there's another bit just there. Just there. And that bit there is the brainstem. And then there's a bit at the back that's shaped like a cauliflower. Which is the cerebellum. So looking at the brain from the side, they're the three main parts. Cerebrum is the largest part on top. Then the brainstem there, and the cerebellum behind. And as you know, the central nervous system is all the tissues in the brain and the spinal cord. So the spinal cord is continuous with the brainstem, which is continuous. Now, because the cerebrum's large, it's useful to divide it into individual lobes. So there's a large lobe at the front, the lobe at the front of the cerebrum, and that's called the frontal lobe. Frontal lobe. And then at the back, there's a smaller lobe. Here, called the occipital lobe. And the occipital lobe is where the visual centres of the brain are. So everything you're seeing, you're actually seeing with the back of your brain in the occipital lobe. That is where vision is generated. So the light comes into the eye, that is transducted into electrical nerve impulses. They go back in the optic nerves, but it's the occipital lobe of the brain that actually generates the vision that you're seeing. And then this lobe above the ears is that lobe there is the temporal. The temporal lobe is above the ears. And the large lobe on the side is the parietal. So this lobe here, this large lobe on the side, is the parietal lobe.
What with an A?
P-A-R-I-E-T-A-L. Yeah.
Is the temporal lobe next to the occipital?
Yeah. That bit there is all temporal lobe. That bit there is all parietal lobe. And that bit there is occipital. Now this is the brainstem here, and this is actually divided into 3 areas as well. The top part of the brainstem is called the midbrain. The midbrain. And the middle part is called the pons. And the lower part you probably know already. Do you remember the lower part?
Medulla oblongata.
Good, well done. The middle part is the lower part. Sorry, is the medulla oblongata. And this bit here is the spinal cord. Right, so main parts of the brain: the cerebrum, cerebellum, brainstem, frontal, parietal, occipital, temporal, midbrain, pons, medulla oblongata, spinal cord, cerebellum. They're the main bits you need to learn. Now, this is looking at it from one side, of course. So if you look at the brain from on top, you would see that the brain's in 2 cerebral hemispheres. Cerebral means to do with the cerebrum. So if we looked at this from on top, this would be the frontal lobe up here. And then depending on your angle you might see a bit of the occipital lobe at the back. That would be the occipital lobe, and that would be the parietal lobe. And if you're looking at it from on top, you wouldn't see the temporal lobe. So the brain's in 2 halves, 2 cerebral hemispheres, one on the right side, one on the left side. Now this area of the frontal lobe here, this area is called the motor cortex. So this bit here, this strip, is the motor cortex. And motor means to do with movement. So this is where movements of the body are initiated. And in here there's a little man, or indeed a little woman, who's more or less upside down. Represented in the motor cortex.
No.
So if you decide you want to move your foot, a new nerve impulse is generated in that part of the brain, goes down through the brain to the spinal cord and out to your foot. If you want to move your fingers, a new nerve impulse is generated in that part of the brain that goes to your fingers. So that is the motor cortex, that area there.
There's the temporal lobe there too?
The temporal lobe is here.
That one.
Yeah. So the motor cortex is part of the frontal lobe. That's the division there between the frontal and the parietal. Now behind this, in the front of the parietal lobe, there's another strip just there. And this strip is called the sensory cortex. The sensory cortex. And it's this area of the brain that is responsible for giving us tactility and our sense of the body. And again, your little man or your little woman is on here, more or less upside down. So when you feel something in your foot, you're feeling it up there near the top of your sensory cortex in your parietal lobe. That is where the sense of tactility is actually generated. And when you feel something with your hand, you're feeling it just there in that part of the sensory cortex in the parietal lobe. So on this diagram, the motor cortex will be in this area here. And the sensory cortex will be in this area here. In the parietal lobe. So that bit there is the frontal lobe. And that bit there is the parietal. So the motor cortex is in the frontal, the sensory cortex is in the parietal. And the really weird thing is, it is the right side of the cerebrum that controls and senses the left side of the body. So your right motor cortex moves the left side of your body. And you can draw a line pretty well exactly down the middle. It follows a very accurate line down the middle. And everything you're feeling on the left, from the left side of your body, you're actually feeling in your right sensory cortex. Strange, isn't it? And the right side of the body is moved from the left motor cortex. And the right side of the body is felt in the left sensory cortex.
Right side of your body, you actually feel on your left side of your brain.
Exactly, yeah, exactly that. Strange, isn't it?
Very.
It is. Can't quite work it out, but it's true.
Did you know, John? I just found this out. That dolphins only sleep with half the brain at a time.
Yeah, I knew that.
I think Jean told us actually.
Yeah, sort of thing Jean would tell you.
Yeah, it's fascinating.
Yeah.
So how comes we can do it with both? How comes we can miss both sides of the brain then?
Well, we don't have to go up for air,
Yeah.
so we can shut the whole thing down at one time. Right, is that a bit okay? Is that okay? It's the basic anatomy of the brain. But now it gets quite interesting. So, what would be best to do? I'm going to rub mine out, but you can draw yourselves a new brain. Yeah, draw another one. You don't need to draw the men on or the lobes, just draw the outline of the brain. Just draw one like this. Now, of course, it's very important that the brain is protected against damage, because you've only got one. And if the brain nerve cells are killed or die off for some reason, then the brain cells aren't replaced. They don't mitotically divide. There is a little bit of cell division in the brain, but it's only a little bit deep in the brain. Most of the brain, the cells don't divide. So you've got to look after the one that you're given, because you don't get a replacement. And we see that the brain is surrounded by this vault of the skull. And these are called the cranial bones. So the bones that go around the skull, sorry, the bones that go around the brain are called the cranial bones. These ones on the front, you could call those the facial bones. But the cranial bones surround the brain. So they go around here. Completely surrounding the brain. So the bony skull is completely surrounding the brain. So cranial means to do with the brain, and the cranial cavity is all this gap inside the skull where the brain is sitting. So everything inside the skull, everything inside the cranial bones of the skull is the cranial cavity. All this inside here is the cranial cavity. Skulls always remind me of Easter eggs. You know, that would be kind of bite that bit, wouldn't you? The chocolate bit. So the cranial cavity.
And is that everything inside?
Everything inside there is the cranial cavity, yeah. But we notice there's a big hole at the bottom. That big hole at the bottom? And the big hole at the bottom is called the foramen magnum. Foramen magnum.
Where's that? Sorry, John.
The foramen magnum is the name of this big hole in the bottom of the cranial bones. So foramen means window. It's like a window in the base of the skull. And magnum, of course, is a type of ice cream. But I guess magnum means big, doesn't it? Mega. So it's the big window. But as we see, in life, what's in the big window? It's a spinal cord, isn't it? So in life, this hole is actually filled up with a spinal cord and a few other bits and bobs that are going in and out of the foramen magnum. So in life, there's not actually a gap. And also, if you look in the base of a skull, there's like a few little holes. A few little holes in the base, in the bottom. And in life, they're filled up with nerves and blood vessels. So in life, in an adult, although there are some little holes, they're all filled up. So it means the skull is indeed a closed vault.
Have they got a name?
The holes have got names, but we won't bother with them. Just little holes. Holes for nerves and blood vessels. Now, if you ever make the mistake of taking a brain out of the skull, what you find is you can't get it back in again. It's like taking a watch. Well, you don't have watches these days, do you? When I was a kid, we used to have watches with springs in. And once it pinged out, you could never get it back in again. So if you take a brain out, it actually expands, it swells a little bit. And you can't get it back in. And that's because there's a pressure in here. There's a little bit of a pressure inside the cranial cavity, and that's called the intracranial. The intracranial pressure is the pressure inside the cranial cavity. And when you're lying down, yours is probably around about 10 millimetres of mercury. Give or take. When you're standing up, it's going to be less, but when you're lying down, it's about 10 millimetres of mercury. So there is a definite pressure in there. Now, if you bash yourself on your arm, or you bash yourself, I don't know, on your leg or somewhere, and you get a swelling, well, you can get a lump, can't you? It can swell out the way. And that's because you get inflammatory swelling. So remember inflammation, heat, pain, redness, swelling, loss of function. Remember that? So when you get an injury, you're going to get an inflammatory response. And an inflammatory response is necessary because it's the first stage of the healing process. So we have to have an inflammatory response. If you haven't got inflammation, you won't get healing afterwards. So if the brain gets bashed, if the head gets bashed and the brain gets bashed inside, so if someone gets hit on the head there, can you see they could end up with a head injury in this area here? Because what can happen is, if, imagine, no, your brain's bigger than that, but if you get hit on the side of the head, like this, whack, can you see that the side of you can see that the side of the skull is going to bash onto the inside of the brain, isn't it? Does that make sense? Now, if you get a little hit, it won't. If you get a big hit, it will. So if you get a head injury, you can end up with an inflamed area of the brain. And that can lead to swelling. We could call that, if you want, a cerebral contusion. Cerebral means to do with the brain, because this top part is the cerebrum, isn't it? And a contusion just means a bruise. So this patient has sustained a cerebral contusion as a result of blunt head trauma. But this causes a bit of brain swelling on this side of the brain. A bit of brain swelling. Yeah, this person's been hit on the back of the head actually in this case, haven't they? But if it's worse, what can actually happen is a head injury can actually damage some of the blood vessels inside the cranium. You can actually damage the blood vessels. And that can lead to an intracranial hemorrhage. So a head injury can cause bruising and contusion and swelling, but it can also cause a hemorrhage. There can also be bleeding.
It just causes that bruising. Does it have some? Can it swell? Has it got room to?
Well, that's a very good question actually. The answer is no, it hasn't got much room to, because in here, very astute observation. In here, it's a completely closed vault, isn't it? So you can't get a lump like you can on your arm. You can't. And if there's bleeding, and you end up with a collection of blood, say there, from bleeding, can you see that's going to form a pool of blood, isn't it? A hematoma. So intracranial hemorrhage inside the cranial cavity, can lead to a intracranial hematoma, a hematoma within the cranial cavity. And of course that can't swell out the way because the cranium is a closed, rigid cavity. So what happens is, if there's a little bit of contusion or a little bit of hematoma in here, that's okay. There can be a compensation for that and the pressure won't rise. But if this contusion is big, or if this bleed carries on, can you see that the only thing it can do is compress the brain, isn't it? Does that make sense? So, cerebral contusion is going to take up more space than that area of the brain should, because there's going to be swelling and inflammatory fluid. And if there's a blood clot, can you see that's taking up space as well? Any of these things can take up space. And anything that takes up space that shouldn't be there, we can call that a sol.
What was that? Anything that shouldn't be there?
Yeah. So anything that's taking up space that shouldn't be there, we can call it a sol. Space occupying lesion. The space occupying lesion. Now a lesion is anything that's abnormal. The lesion is anything abnormal. So here we have abnormalities as a result of an injury. But because space is at a premium in here, because we can't get swelling, if it's taking up space the main point is just that, it's taking up space. So we call it a space-occupying lesion. So head injuries can lead to the formation of space-occupying lesions. And if a space-occupying lesion gets too big, it's growing inside the cranial cavity. What's that going to do to intracranial pressure? Can you see that could result in raised intracranial pressure? So space-occupying lesions can lead to raised intracranial pressure. RICP. Raised intracranial pressure. So the sequence of event is there is a head injury that can lead to an intracranial lesion, such as a cerebral contusion or an intracranial haematoma. If the space-occupying lesion grows beyond a certain point, the cranial cavity can't expand, and that's going to lead to raised intracranial pressure. So SOL can lead to RICP, raised intracranial pressure. Does this sound like it might be fairly bad news, actually? You see, we're compressing the brain here, aren't we? You're compressing the brain. And really, we don't like compressing the brain because the brain can get damaged. So local pressure can damage the brain. And if the pressure here gets more and more and more and more, if you get really extreme raised intracranial pressure, where do you think the weakest point of the skull is? The weakest point of the cranial cavity is? It's going to be the hole at the bottom, isn't it? So if the pressure is really, really high, can you see that that could mean that bits of the brain actually get forced down through that plug hole on the bottom, like that? Does that make sense? Bits of the brain could eventually get forced down through the foramen magnum. And at post-mortem, if this has happened to someone, and you look at the bit of the brain that's been forced down there, it's kind of got a cone-shaped, becomes cone-shaped, because it's been forced through the foramen magnum. And we call that coning. So raised intracranial pressure is seriously bad news. Firstly, because it can damage the brain, which is bad enough, but then it can force the brain, the bottom parts of the brain, down through the foramen magnum, down through this hole in the bottom of the skull. How long do you think you'd live if bits of your brain were forced down through there? You'd be dead, so it's instant death, isn't it? Well, you wouldn't be standing around, but if you were, you'd be dead by the time you hit the ground. That would kill you straight away.
And that's called coning, is it?
Yep, that's called coning, because you get this cone-shaped tissue. What do we do with dead patients? Well, you might do, yeah, but I mean, basically we take them to the morgue and then communicate with the grieving relatives, don't we? So,
If you take the brain out and post-mortem, you can't put it back in?
no,
In the tummy?
yeah, they just put it in somewhere else.
Why? I don't know how.
Why? Well, what are you going to do, chuck it out? I suppose you could chuck it out.
Put it in the grinder.
Send it for research or something. And why would you take it out?
Well, no, I can't understand if you did take it out, why you would put it back in the stomach.
Well, because it expands. You can't really get it back in. Well, people get upset if the relatives aren't buried complete. People have strange ideas about death. Now, can you see, given that we can't treat death, we have to try and arrest the process before it happens, don't we? So we have to intervene at a much earlier stage. Unfortunately, we can intervene at a much earlier stage. So, let's think about... Let's imagine that this is a blood vessel here. And as we know, blood vessels divide to take blood to areas of tissue. So here's an area of the brain getting blood from this vessel. Now normally, the blood pressure in this artery, taking blood to the brain, is going to be around about 100 millimetres of mercury. I know it might be 120/80 or something, but the average is going to be about 100 millimetres of mercury. And we call that the mean arterial blood pressure. So normally there's about 100 millimetres of mercury taking blood into the tissues of the brain. And the brain is a very metabolically active organ. It's doing stuff all the time, even when you're asleep. Uses a lot of energy. So actually about 20% of the blood that's pumped out from your heart is going to your brain. The brain needs a constant, large volume of blood to keep it going. Actually, if this vessel is taking blood to the brain, can you see this vessel here? This blood vessel itself must in fact be intracranial. This whole thing here must be inside the vault of the skull. Does that make sense? This whole thing's inside the skull. So we've got 100 millimetres of pressure there, taking the blood in, which is fine. But come to think of it, we've got intracranial pressure normally, haven't we? Does that make sense? We've normally got intracranial pressure. So can you see that intracranial pressure is going to be squeezing the blood vessels that go through the brain? Does that make sense? There's a pressure. And we said that pressure might be 10 millimetres of mercury. So do you see what we've got here is we've got 100 millimetres pushing in, and we've got 10 millimetres trying to squash it, trying to keep the blood out. Does that make sense? 100 pushing in, 10 trying to stop it. But can you see that still means that the perfusion pressure here is 90 millimetres of mercury? Is that logical? So it's okay, 10 millimetres is fine, because if you've got 90 millimetres of pressure getting through to your brain, that's fine. Average pressure, that's fine. That'll keep your brain happy. And if your brain is happy, can you see the brain is free to generate consciousness? It is the brain that generates consciousness. So as long as the brain is getting this blood supply, it's going to generate consciousness for us, which of course is nice. But if we've got a space-occupying lesion that's raising intracranial pressure, can you see we're going to have more pressure on here? This could have gone up. So now there's 100 pushing through, if we've still got 100 pushing through. But can you see now we've got 30 trying to keep that 100 out? So how much pressure is getting through to the brain now? Only 70. It's dropped, hasn't it?
John, sorry for your PM. Can you make consciousness on the board? I don't know what else, right?
Probably not. The trick is not to think about it. If I thought about it, I couldn't have spelt it either. And especially if this person's been in an accident. So imagine they've bashed their head and they've broken a bone or two. Do broken bones bleed? Broken bones bleed a lot, that's right. So can you see their blood pressure might be even lower than normal anyway? So the blood pressure might not even be 100, it's 100 at best, isn't it? So especially if that's lower, the blood pressure's down to an average of 80. Heck, can you see now we're down to 80 minus 30, which is... we're way down now, aren't we? But even if that blood pressure's normal, if the intracranial pressure rises, that's going to reduce the amount of blood getting to the brain. So normally the brain needs its blood supply because it needs its oxygen supply. Without that, can you see the brain is going to become hypoxic? Does that make sense? You're going to get hypoxia. And because it's the brain, it's cerebral. Hypoxia means a reduced oxygen level in the tissues. Normally, what's the brain using all this oxygen for?
John, what did you say that was again?
Cerebral hypoxia. Cerebral means to do with the brain, the cerebrum. Hypoxia is lack of oxygen. So what's happened is there's an injury that's caused a lesion. The lesion has expanded and it's become space occupying. It's now a space occupying lesion. The space occupying lesion has raised intracranial pressure. The raised intracranial pressure is pushing on the blood vessels. That's reducing the amount of blood that's getting to the brain tissues. If you reduce the amount of blood, you're reducing the amount of oxygen. That's going to cause cerebral hypoxia. That means the brain can't generate energy as usual, and that means the brain can't generate consciousness as usual. So can you see raised intracranial pressure can lead to reduction in levels of consciousness? Does that make sense? So as we increase intracranial pressure, conscious levels can be reduced. How do we measure levels of consciousness? Jean hasn't taught you this yet, has she? GCS. We measure levels of consciousness by the Glasgow Coma Scale. And when you are fully conscious, your GCS is 15. I'm not going to tell you how to do that because Jean will do it. But when your levels of consciousness are normal, your GCS is 15. So can you see that if someone's level of consciousness is reducing, if the GCS number is going down, that may well mean that the ICP is going up. Does that make sense? So the higher the intracranial pressure, the greater the cerebral ischemia and hypoxia, the lower the Glasgow Coma Scale will become.
Can you please say that again, John?
Yeah. What did I say?
The higher the intracranial pressure.
Yeah, the higher the intracranial pressure, the less blood will be getting to the brain. It'll be more ischemic. Remember, ischemia means a reduced blood supply, doesn't it? So the higher the intracranial pressure, the less blood supply is getting to the brain. There's going to be cerebral ischemia. The less blood supply gets to the brain, the less oxygen will get to the brain. There'll be cerebral hypoxia. Therefore, the brain can't generate consciousness as normal. Therefore, the Glasgow Coma Scale reading will go down. So as intracranial pressure goes up, Glasgow Coma Scale goes down. So can you see, if we can learn to do GCSs, if we can learn to ascertain what level of consciousness a patient has got, can you see we can use that as a proxy for measuring ICP?
Yeah.
Now you can drill a hole in someone's skull and stick in a manometer and measure their intracranial pressure directly. Neuro units do that, but we don't want to do that to everyone who's had a head injury, do we? We would have people walking around with holes in their heads all the time.
But you not put something like, like that's a stent. If you have a stent in or a stent.
Yeah, but again, that would be a significant surgical procedure, wouldn't it?
Does that relieve some of the pressure? What does that?
A stent is something which increases the lumen of something.
You wouldn't just put a stent in your brain, you wouldn't it?
No, you would put a stent in vessels that drain the brain, but forget that for now. So can you see, if we can measure level of consciousness, then from that, if we can measure level of consciousness, from that we are inferring what the intracranial pressure is. And if the GCS goes down, we can say, this patient's GCS has gone down, their level of consciousness is now reduced. I wonder if this means that their intracranial pressure has gone up because their space-occupying lesion is getting bigger and compressing their brain further. If so, I better intervene before we start getting compression of the brain and brain damage, or before the patient cones and dies. It gives us a window of opportunity. So that's why we need to measure levels of consciousness. Yeah?
Could it cause a tumour as a cell?
Yes, it would. You can get similar effects with tumours, or abscesses, or infections, or many other things. The thing is, with tumours, they tend to grow very slowly, so there's more time for adaptation. Whereas these things can grow quick. Right, what you need to do now is explain to your next door neighbour why a lesion can become space occupying. Hang on, listen. Why it's significant that it's space occupying. Why space occupying lesions can lead to raised intracranial pressure. Why raised intracranial pressure can lead to cerebral ischemia and hypoxia. And why cerebral ischemia and hypoxia can lead to reductions in the overall level of consciousness as measured by the Glasgow Coma Scale. Do you understand the task?
You do this on purpose, you know we don't.
Yes, you do. You're the only one that doesn't. Right, tell your next door neighbour. Off you go.